Let me share my screen. All right. Can you guys see that?
There we go.
Okay. Morning, everyone. So this is going to be a collaborative effort. So I have a couple of slides, but then really wanted more discussion based, and I'm going to ask for Terry and Candy and Rick and Mickey to kind of do a little mini panel discussion to walk us through the CPS process, as well as goals and limitations when individuals become involved with Child Protective Services. So we'll quickly overview the numbers, which are pretty remarkable in terms of West Virginia really leading the nation in some of the highest numbers of individuals involved with child welfare and the Child Protective Services system. We certainly know that the system is overwhelmed. And we'll talk about what populations are most commonly involved, and then the process. And talk a little bit about models that are out there. And I'm curious to hear about people's experience with these models. Again, happy to have people jump in the middle. People don't have to hold questions to the end. And if anything that I present is different than what your understanding is or inaccurate in any way, please absolutely jump in and let me know. So I'm social work faculty in the Department of Behavioral Medicine and Psychiatry, and I work in a variety of clinical settings, including with pregnant women with substance use disorders. And so I have lots of experience with patients who may be involved in Child Protective Services at some point during their treatment with us for substance use disorders. So in West Virginia, these are the most recent numbers that I could find. About 6,700 children are currently in foster care, or this was the number in 2020. We have certainly seen a steady increase in these numbers during the opioid epidemic, and then with methamphetamines coming onto the scene, it's actually made the situation worse, because we know that individuals who are actively using methamphetamines are typically even more severely impaired than those using opioids. And so I think that this has really increased the burden on the Child Protective system. The numbers of children in kinship foster care, it's about 7 to 9% of the population. We are the second highest in the nation, just behind Mississippi, of the numbers of kids in foster care. And in 2019, 2020, compared to the national average of 5 in 1,000, in West Virginia, it's 20 per 1,000. And again, increasing since 2014, which is really in lockstep with the increasing numbers of individuals impacted by opioid use disorder, as well as overdose deaths, so kids who have lost parents because of the disease. Child abuse and neglect cases are also high, not the highest, but third highest in the nation in 2019 and 2020. And people are probably familiar with the rates of neonatal abstinence syndrome are the highest in West Virginia. And so that's where babies who are born exposed to substances in utero develop withdrawal symptoms after they're born and need treatment. Sometimes that can include non-medicinal treatment. Sometimes that can include medicine for treatment. Just in terms of neonatal abstinence syndrome, this is just kind of a nice graphic. When we look at the areas that see the highest rates, Mon County is kind of in there in third place. Well, actually, no, Mon County is better. Mon, Marion, Preston, Taylor, Harrison actually do better than other regions. And it's the Northern Panhandle that struggles the most. Although in talking with the folks who collect this data, some of the things they've shared with me is actually that Sometimes this is a little bit skewed by reporting rates, not necessarily incidents. So it may be that hospitals where delivery occurs are more likely to report rather than this being entirely reflective of incidents. But regardless of that, we have very high rates in West Virginia. And obviously that will often trigger a CPS referral when kids are exposed to substances in utero. And the problem in West Virginia is fueled by the substance use disorder problem. Drug overdose mortality rates, again, highest in the nation, have been highest in the nation since 2009. And West Virginia is highest in child removals. And all of these have been steadily increasing. So increased number of cases that are accepted. So a case obviously gets called in and not all of them are accepted, but increase in acceptance. Increase in open cases over the last 3 years and increase in adoptions. So if you guys were feeling overworked, it certainly makes sense, right? Many more kids coming into the system. And so who typically gets referred? So 83% of open CPS cases involve substance use. And so that's really where the intersection with treatment comes into play. We hope that individuals, and we know it's fairly standard for someone who's referred to Child Protective Services, if they aren't already receiving substance use treatment, that they get referred to do so. And so that's where we really intersect. The coordination of services is really important because I think to have the whole story of what's going on with an individual, I think Child Protective Services sees one thing, and obviously then there are people in the home in terms of parenting folks or those who are observing child visitation and then treatment. And so really being all at the same table with the client to talk about what's best for the family and what's best for the kids can be really important. There are barriers to doing this. Time probably being what I hear the most. People don't have enough time to make the phone calls and do the outreach and coordinate services. It's a huge barrier to be able to doing this well. Not having contact information or releases, that takes time also and can not always flow. And then trust. Sometimes it feels like we're not all on the same side. And that's actually one of the reasons why we wanted to have the ECHO, is so we can have some of these discussions and present some cases where we talk about, here's a case that's likely very familiar to both of us, and how might we approach it differently? How do we maybe come up with common goals, and then really help the client be involved in realizing those goals. So we'll talk a little bit about models where we might be able to improve communication, and also happy to hear from everyone about thoughts about how to do that. The other common folks who get involved with Child Protective Services are individuals who are pregnant and have substance use disorders. So just a reminder, people often wonder about filing or making a report of a pregnant person, but really CPS, in my experience, will not take the case if there are no other children in the home until after the baby is born, because of how the laws are about what constitutes a child. And pregnant women who give birth and are on medication for opioid use disorder and test positive for either their prescribed medication or other substances, that's an automatic kind of call to CPS while they're in the hospital. And how that gets handled seems to vary by county, because we see folks here in the hospital from lots of different counties, especially if the babies have any issues. We pull from fairly wide geographical range. And sometimes Child Protective Services folks come to the hospital. That's most often the case. And depending on the situation and if other kids are at home and the situation with mom, what happens next can vary. Cord blood is another objective tool we use to kind of capture whether the baby's been exposed, and can be, a good way to start a conversation with mom and help with her being honest about what she may have used during her pregnancy. Important to note that it is not uncommon for women to be administered narcotics for pain control during the course of labor. And so it's really important for all of us to have that awareness. Fentanyl is commonly administered. And what I have found in our own hospital is the patient sometimes is not told, which is a problem. And so I'm trying to work with our OB folks that if you administer narcotics to this person, especially if there's any risk of CPS being involved, you have to let them know so that we can provide the appropriate paperwork to whoever needs it related to medications administered, because that has created some problems. So I'm going to kind of open it up to the panel discussion. So for Rick and Terry and Mickey and Candy, these are really kind of questions that we have and that many people in treatment settings often have about what are the goals, limitation, and process of the CPS process. So from the initial report, what's the timing, like what's supposed to happen after that? I don't know if you guys can walk us through this process.
We can. When the initial report comes in, the initial report usually goes to our centralized intake unit. And then they make the decision there of whether the report meets the definition of child abuse and neglect by West Virginia State Code. If they make the decision that it meets the definition, then they accept the referral and they then send it on to the county office where the family lives. And we have a certain timeline where we have to make a face-to-face with that target child and the rest of the children in the home. And that is usually within 72 hours, unless there is imminent danger and we have to make an immediate 24-hour or 2-hour contact. And we do our best to hit those timelines. And honestly, even with our staffing issues, I think we do pretty good at hitting those timelines and seeing the initial, making those initial contacts with the child to make sure the child is okay. At that point, we need to make a decision of whether the child's safe and whether we can keep that child safe in the home. Because removing a child from the home is always is the last resort. If we can keep a child safe in the home by some type of safety plan with another relative, a friend, somebody that can be in the home, be safe, help the child be safe in the home with the parents, then that's what we want to do. If we can't ensure that safety and we have to remove, then we still always try to find a family member if we can. A family or some type of a kinship placement, and that doesn't have to be a blood relative, but some type of a kinship placement where the child's going to be less traumatized from being removed. And different, you're right, different counties and different judicial systems handle that different ways. And there are certain counties that remove. There are certain prosecutors' offices, certain judges that remove quicker than others. I don't know how to say that any differently.
I think also that in some counties, that's the expectation that is left with CPS, with between the prosecutor and the court. I think it's the expectation for CPS to remove those kids. You know, just as an example, in Harrison County, we don't remove kids without first having consultation with the supervisor and then having consultation with our prosecutor. I mean, and we do not just because the court said so. I mean, we don't do that. You know, but I know in some counties that's just the expectation. And, you know, of course, in those counties that, you know, those CPS workers have no control over that. But, you know, and of course, there's not much, you know, the agency can do about that. But
yeah, so you're saying that expectation is sort of set by the court system.
Yes.
In that county, yeah. Okay.
It is. It is. Like in Mon County, I know that we're like Terry, you know, we consult with the supervisor, consult with the prosecuting attorney, you know, we have argued with the prosecuting attorney, you know, no, we can keep these kids safe, or, you know, we've wanted to remove and they haven't felt we've had enough. And we've also had to remind the prosecuting attorney, no, you work for us, we don't work for you, you know. But, you know, recently we've had a pretty good relationship, you know. She said, you know, I don't think we have enough, but I'll, you know, if that's what you guys want, we'll do our best, you know, we'll go and we'll see what the judge says, you know. But or the opposite, you know, she's thought we should remove at times where we've said, no, we can keep this child safe. And so, you know, we have those discussions.
And at those discussions, this is pre-MDT, right? So this is at the sort of acute stage of like removal or no removal. Yeah.
Yes,
Yeah.
this is before any MDT. This is at the initial stage of, are we going to, at investigation, are we going to remove, are we not? Because we don't like, again, we don't want to remove children from parents if we don't have to. You know, we know we're removing someone's children from them. That's big.
Yeah.
You know, we're not the kidnappers, quote unquote, that people tend to think of CPS. We're here to save families, not destroy them, you know, if we can. I mean, that's always our bottom line.
Mhm.
And even if we remove children, reunification is always our bottom line, if that's possible in any way. So we are here to help families, not destroy them. So that's hard for people to understand because we've gotten such a bad rep over the years. But
And then
that's
is there, I don't know if it varies whether the child is removed or remains in the home, like how quickly like an MDT meeting gets scheduled, or the court, like are there general guidelines on when a court date should be set if a case is opened and when the MDT meetings get scheduled?
well, not always. Like if we have an open case on a family, we don't have MDTs. You only have MDTs if there's a court process.
Okay.
So sometimes if we can maintain safety through a safety plan, get services in the home, you know, we use informal and formal resources. So we make referrals for parenting, adult life skills. We get the parents involved if there is a drug issue, either get them in inpatient treatment or get them referred to outpatient treatment for their substance abuse. And we use informal supports like family members that will come in either to, like, just as an example, if there's a mom and a dad and the dad works and the mom can't be unsupervised with the child or the children in the home, we'll put informal supports in the home for one of two things: either the mom during the time the dad is not there she needs to go either to her, like say her mother's house while he's working, or we have grandma come to her house for supervision purposes. And then obviously the services would be going into the home to provide, parenting and all of those kind of services. So if we just do an in-home case, there isn't the MDT process. The MDT process is involved when we have court involvement. Now, sometimes we have court involvement where kids may be with their non-offending parent, like parents are divorced or parents are not living together, and we put the kids with their biological parent, whether that's mom or dad. And we're in courts because we can have court cases where kids are with the other parent. And then the MDT process is involved in that. Or with obviously kids that are removed in or either in kinship placement or foster care placement.
It's really helpful clarification. Any questions from, I can stop sharing for a minute. Any questions from the group for our expert panel? I'm the only one with all the questions.
I have a question.
It's okay. I would prefer people ask questions.
Yeah, go ahead, Tina.
So the centralized intake acceptance or denial unit that you were discussing at first, do they basically solely base it on whatever the laws are at the time, or like what are these folks' qualifications to determine an acceptance or denial of a report?
They are also CPS workers.
Okay, so they are off the bat. Okay.
And actually there's the CI workers who take the reports, and then the supervisors are the ones, and the supervisors have been previous CPS workers,
Okay.
a lot of them, and they make the supervisors at centralized intake are the ones that determine whether the referral is accepted or not.
Okay.
They are CPS workers, CPS supervisors, just like the rest of us. They just run the centralized intake unit.
I have a question. So is there a different process or steps to follow with teenagers? Or is it very similar? Do they, have an option? How do you handle teenagers?
You mean if a report is made with a teenager being a target child?
Yeah, if there's a report made and it's, someone who's 13, 14, 15, something like that.
That are using substances, or
Yeah,
that are,
if there's a report made on the family, on, the mother, the father, whoever the teenager's living with, and they're taken out of the home, or, how does that process ensue? Do they get an option, or is it more,
the process is the same, whether we're talking younger children or teenagers. If we are doing an investigation and we feel that all the children in the home are unsafe, then all the children are removed. As far as giving teenagers options, obviously we try to find family, appropriate family, and we do. So as far as, if we're taking custody of kids and we look at a family, part of their biological family, or even if it's a kinship placement, we still have to look at if they have CPS history, if they have substantiated maltreatment of any kind of removal in the past, been adjudicated by the court. We can't place the children there because the children are not going to be safe there. We also do criminal history and criminal background checks, which we contact our prosecutor's office and we get birthday social security numbers, and our prosecutor's office runs background checks on people. Because part of that process is they also have to complete a home study if kids are in our custody and placed with them. And they have to complete a home study. And if they have criminal history, where if there's drug involvement, if there's criminal history as far as like a charge against a person, they're likely not to be approved as a foster parent, which, we don't want to place children and then have to move them. I mean, when we place children, we want to keep them in the same place. So we kind of do all this stuff ahead of time to make sure that when we place kids, we don't have to move them over and over. But no, I mean, if we feel that a 15-year-old is unsafe in his home, then he'll be removed just as well as his other siblings.
Going back to your question, a lot of the times those older kids are good sources of information for us to find an appropriate relative or kinship placement. So, their thoughts are taken into account. It's just we can't leave them in an unsafe situation because they don't want to leave their home.
Right. Now, what one might consider an unsafe situation for a 2-year-old may not be an unsafe situation for a 15-year-old, so we have to weigh that out. But, or maybe not quite as unsafe for a 15-year-old as a 2-year-old. A 15-year-old can get something to eat themselves where a 2-year-old can't. But safety is safety regardless. And we want to ensure that all children are safe in the home. And, by code, if we remove one child, we're going to remove them all.
Because under the code, like Mickey says, it's if one child's abused, they're all abused. So, and all of them have to be removed.
Thank you, guys.
But again, our goal is always reunification. Now, way on down the road in a case, when you're asking, does a teenager have a choice? Way on down the road, if the family's not cooperative and you end up in termination of parental rights, then even if you're not going to place a teenager back in the home, after a certain age, by law, the judge has to take into consideration the feelings and the wishes of a teenager. Do I want my mom and dad's parental rights terminated? Do I want to be adopted? So the judge takes an older child's wishes into consideration. Where
I'm sorry, Mickey, go ahead.
No, it's okay, Terry. Where with a younger child, we want stabilization. We want them to have the most normal life that one can have, and be stable. An older child already knows what's going on, and they have a right to express their opinion, and the judge will listen.
The other thing too is all the children, if we take custody, have an attorney. They have a guardian ad litem who will meet with them and talk with them. The other thing too is if it's felt appropriate, a teenager can attend MDTs and teenagers can attend court hearings. And of course, the judge obviously looks at the GAL for that recommendation as far as if they feel it's appropriate for the child to be involved in the process. So that's another thing for them to be involved in this process is that, like I said, they are able to attend MDTs and court hearings if it's deemed to be appropriate.
So one final question, just very like a detail, like if there is a removal, is the court date supposed to be set within a certain amount of time? And is that dependent on the child's age or not? If it's an infant versus a 10-year-old or?
No, it's all the same. So when we take emergency custody, we have 2 judicial days to file a petition. So say we take custody today, we have to file our petition by Friday. And then once the petition is filed, the judge will enter it. And then from Friday, the hearing will be within 10 working days. And I mean, that's just standard. Doesn't matter how old the kids are, what the ages are, or anything like that. That's just our process.
And then after that, MDTs begin to happen after the initial court date.
Correct. Well, and then within 10 working days, the preliminary hearing will be set. And in our county, once we're together at the hearing, then we set an MDT.
Okay,
To get that process started.
great. Thank you, guys.
Right.
And we have- Go ahead.
Each parent is also appointed an attorney. So if, if there's mom, dad, children, then you have mom's attorney, you have dad's attorney, you have the guardian ad litem for the children, you have the prosecutor, the judge, so everybody's well represented. Prosecutor representing the department. So yeah, everybody's well represented. Nobody's should be, run over by the system.
And in cases where you have like a mom and a stepdad, and then there's biological parents, like a biological dad or a biological mom, they're all involved. Everybody's involved. Everybody has attorneys. So everybody's represented.
And the
Yeah.
treatment, so the treatment plans that are determined at the MDTs, those are all, like, everyone involved is made aware of those goals.
Everybody involved is part of setting those goals.
Okay.
So
Everybody is involved in setting that treatment plan. And, it's that's what an MDT is a brainstorming of all the different professionals and what are we going to do to help this family? It's not always, not everybody always has the same idea of what needs to be done, and we hash that out. But it's always to be for the betterment of the family.
Are the families involved in setting the goals too?
Absolutely.
Yeah.
yes, the parents are involved through the MDT process. They're at the MDT meetings.
And the CPS worker meets with them, and what are we going to do? And this is the problem. And what do you think you need? And what do this is what we see. What do you know? So yes, the family's absolutely involved. Now, they don't always see their substance abuse issues. And I say that because that's the main problem right now. Like, you said at the beginning, Laura, that's the big issue right now in West Virginia. I know when I retired and came back, my first question was, what happened to dirty house referrals?
Right. Yeah, I mean, when I saw that 83%, I didn't realize it was quite that high.
Yeah, it was headed that way before I retired. And I was up in the Northern Panhandle. I managed Ohio Brook Hancock for a few years. And I know that Route 22 that ran from Pittsburgh to Steubenville, Ohio. When I was in Weirton, we called that Heroin Highway because that's just, it's bad. There's no doubt in my mind when I saw that was the dark red, or when I saw that was the number 1 up there, I know that was dark red because I finally figured out you did that show in the different regions. But when you said that was number 1, it didn't surprise me. But
I know we have a case, so people also can ask questions. I think the case will probably bring up more questions. So Amanda, do you want to go ahead and your case presentation.
Sure.
And just a reminder for everyone who's relatively new to ECHO, cases are the way that we make a lot of the material come alive. And so everyone is encouraged to submit cases. And there's a case form. I think that Jay, you send this out with the recaps and stuff, right?
Correct. Yep.
And it's just like you just fill in the blank. It's an easy form to fill out.
And it's also, you don't have to fill out every part of the form. You just fill out what you have. It doesn't have to be paragraphs. It can just be bullet points, just to get something down, to get the discussion going.
Yep.
Okay. Yeah, so I definitely didn't put all the information I probably could have on here because I would rather talk about it. But and as I was reading it this morning, I was like, I already messed up on this. So the client that I'm using as our case today is a 32-year-old. She's not married. She just has a significant other that they live together with their 2 children. Her significant other began using substances and she soon followed. So she soon relapsed and got involved in using substances, and it just escalated from there for the 2 of them. The case was actually referred because there were several domestic violence incidents. So the police have been called several times, and then the case was referred to CPS. The children did end up getting removed. And right now, like the mother's been in this process for about a year. She has weekend visits, and some weekday supervised visits, and some MDT meetings at this point. The kids are with her mother, so they're in kinship care. She's involved in the RDVIC, so she does some classes there. She's in substance use disorder treatment. She completed her parenting classes, and she's in drug court too. She's very engaged in treatment and with providers. She's super hesitant with CPS. And part of that is because the caseworker has changed. So she had one caseworker that she really got close to, and then the caseworker changed. So now she's super hesitant because it seems like some of the goals had shifted, and maybe I think more or less like where some of the goals, like where she felt a connection with her case manager and some of the goals that they were working towards together. And when it shifted to a different case manager, it seemed like that case manager saw the need for goals in different areas. And so she really struggled with some of that. And then her lawyer changed too. So then her lawyer ended up quitting and she had to get a different lawyer. So now you can see these trust issues just building up. And it seemed like, some of the things, and this is part of my questions, were some of the things that were coming up at the MDTs and some of the reasoning why she was held back towards visitation and moving towards visitation was really based off of her ex's like behaviors and what he was going through. And so I thought that was interesting that, she was being held accountable for some of his behaviors too. So she had to separate her, and maybe you guys can explain that a little bit more, but she had to separate her case where it was like considered together for a while, even though they weren't together. So the attorney had to separate the case for her. So the barriers, of course, are her trust in CPS. We worked on that almost weekly on her. I mean, it was to the point where she didn't even want me to advocate with CPS because she was afraid that that anything would go against her. And so she was just really fearful. This was her first involvement, and her children were like removed from the beginning. And so I think that scared her a lot. And then I think the changes led to some of those trust issues. Several drug testing sites. So I see this with a lot of my patients, but being, with drug court, she has to drug test for CPS for us and then for court. And so, she would be drug testing like 3 or 4 times a week. And sometimes she'd have to like run to go to get places. She didn't have transportation. So many of the times she walked. And if she misses, then it's considered a positive. So she did miss a couple. but she did not relapse this time. She has several services involved. I think that sometimes can be challenging because I think many of our patients have so many different services involved. They forget who's what, and they're not really sure what they're even doing. And sometimes it's not even beneficial at that point. She felt like her treatment goals were unknown. When she attended the MDTs, treatment goals were made clear, but she said she felt like it changed every now and then. So like at one point, and I think identifying how to prioritize her goals would have been helpful for her. Again, that was a huge barrier that she didn't want me to get involved, so I couldn't clarify any of this. But she prioritized needing to get a job as number one, and then housing, and then her substance use disorder treatment kind of came down there on the totem pole, because she's like, well, part of my treatment goals are I need to get a job and housing, and so she really focused on that and had a hard time prioritizing that, and we really had to work with her on reframing her thoughts into putting her treatment first, because if she doesn't sustain sobriety, she's not going to be able to maintain those pieces. And so we really had to do some work to encourage her to do that. So what recommendations did we have to increase success? Following treatment plan more closely with CPS. Because she didn't want us to get involved, I really advocated for her on a daily basis to contact, if you have questions, contact your case manager, stay involved, and then she did, and then her case manager changed. That was the part that stuck. But and to continue to focus on the positive, just kind of reframed some of her thinking on, you're doing what you need to, you're following these goals. So, but I think it's sad because I was trying to, when she did get a different case manager, I was trying to help her identify, this is a new case manager that's coming into how many cases, really just probably, coming into this service altogether. And so learning your job, having all of these cases. So when she wasn't getting calls or she wasn't getting any kind of anybody touching base with her, she really would create monsters that really weren't there, right? So it was that, now CPS is looking at her differently, and that she's not sure if it's successful and what's the point of even trying. And so kind of losing hope at that point. And we worked hard. I continued to reinforce with her, you have a new case manager, give her some time. This is going to take some time for a transition. And so I had to really reinforce that. But so that was definitely some refocusing we had to do. So I guess my questions were, and you answered one, how can we encourage more transparent treatment plans? Sometimes I feel like, and this seems to be a theme consistently, and I don't know how we could help to increase this, but if our families are involved in creating the treatment plans, clearly they should know them, right? But what I'm thinking in listening to some of my patients, I can only imagine. I think of when you're, and maybe this is a terrible metaphor, but I think of when you're going in because some of our patients are so fearful when they go into the MDTs. I'm wondering if this is kind of like a medical diagnosis, when you go in for a major medical diagnosis and you don't really comprehend everything that's being said. I'm wondering if that's kind of something that our families are experiencing, they're not really comprehending everything that's said. So then they don't really grasp all of these goals and what it's like for them. And then they have a hard time kind of meeting some of them, or this case, even prioritizing, okay, so what she heard was I need to get a job and I need to get my own place. And that's what she focused on, right? And so really not looking at it as a whole. So really finding a way to prioritize. And just wondering how domestic violence victims are reviewed and held accountable for if they're still a couple, are they considered together? So if one follows through with their parenting classes and the other doesn't, do both get held accountable? So I guess that's what she was seeing, is she was being held accountable for some of his actions. Increasing communication with treatment and urine drug screens, like if there's a way we could, and I know we've brought this up before and talked about it, but a way that we can condense all of the urine drug screens, like if we could all use the same one or provide each other with some of those results, I think that could be helpful. Yeah, and encouraging clients to just trust the CPS process more. We do a lot of reframing around that. And like I said, I think there are things that lead up to that. Turnover is definitely one of that. I know that you all are experiencing a lot of turnover and it's hard. And I can't imagine being a CPS worker and coming into all of these cases and trying to figure out my job. But then you have these parents on the other end who are like just dying and waiting for a phone call and they don't get one for 4 weeks. So then they're like, ah. So we're like calming them down, like this takes some time. So yeah, those are my questions.
Well, as far as the treatment plan here in Harrison County, I mean, we have what's called a uniform case plan. Our judges do not like that plan. So, because it's convoluted and it really doesn't individually spell out treatment goals and how to accomplish those. So we have to do those, but we also do our own and we write out everything. And it's turned into the court and it's given to all the attorneys and to everybody. So here they should have a 2 or 3 page document that tells them what their goals are, what the treatment part is, what the goals are. And so that's what we do. So we kind of do a double process because by law, we have to do the uniform case plans, but our judges do not like them. And we personally don't like them either, but we have to do them. So because they don't make sense and they're convoluted and they're 15, 16 pages long and you can't figure anything out in them. So we kind of do our own.
Yeah, I can see where someone would get kind of lost in that.
Yeah, so we kind of do our own and specify and do that kind of stuff. So and if the parent doesn't get a copy of that, they should, and if they don't, they need to ask for it if it's somebody from Harrison County, because that's what we do. So
do they get a copy of the one you don't like or the one that you do yourself?
Well, it's
Or
all
both?
it's filed with the court and all the attorneys get that. So, and obviously, you know, a lot of times the attorneys are supposed to be giving those to their clients. Because when we do stuff, we send in discovery and the prosecutor disseminates it to everybody. And then the attorney should be giving that to their clients.
But it is confusing. And if it confuses us sometimes, and we can see how confusing it is, I know it confuses the clients. And like Terry said, that's why there's another one that they do. And Terry, if you'll send me a format of what you guys use, I would like to see that. But because I know we did that in Wetzel County too. But if we can simplify it for the client, it's much, much better. So yeah, here's your goal and here's the steps to reach that goal, you know. So
I mean, and obviously prioritizing your goals. I mean, number one, if we're in a case because you were using drugs and there's DV in the home, of course, those things are priority. But part of their treatment plan is they have to have appropriate housing. They have to be getting a job and all of that. But that doesn't need to be obviously the priority, and you let everything else go. So, I mean, it's a balance thing. And some people just hone in on one thing and then they don't want to do anything else until they get that one thing accomplished. But like you said, if it's issues with drugs, you're not going to be able to maintain unless you're dealing with that first. So you have to deal with what the cause was for us to remove the children before you delve into dealing with these other issues.
As for what you were asking about accountability for somebody else's actions, we're looking at the safety of the children. We're not looking at whether or not he did, she did, they did. We're looking at, are the kids safe and can the kids be returned safely to that home? If she's still involved in a relationship with a man that's domestically violent, who's not getting any services, he's not following through with any of what we're asking him to do, and she's still involved, we obviously can't say her children would be safe to be returned to her. So that's an issue. And the courts are not going to return kids to a situation like that. And we're not going to recommend it. I don't know if that's the question you were asking.
Right. Yeah, it is along that, but like, would she be able to, like, if she's, because she was not with him, I mean, there were still incidents where he would come around, but that's typical with domestic violence, you know. And there were, she had relapses within that, right? So she had at a point, you know, where she did talk to him for a day or two and then went back to not talking to him. So naturally that kind of put her back some. But if she's moving forward with her treatment and she states she's no longer with him, you know, could she move forward towards like visitation and seeing her kids more?
Well, first of all, she should be having visitation.
Well, she is now,
by
yeah.
herself, but even prior to that, she should have been having visitation, whether she was still maybe having contact with him outside of that visitation. That visitation would have been supervised, and there's no reason for her not to have had visitation. I'm kind of confused about that.
Yes, she didn't have visitation for a very long time. And it actually didn't move towards visitation until her lawyer had to separate their cases. So it was no longer their case. She separated the two cases. I don't know how, but
well, it's as far as the court, it's all one case because he's obviously a respondent and so is she, but I don't know how the attorney separated it.
I don't know.
I'm kind of confused about that because it's one case in front of the court.
Especially
sometimes they call it separating because they put them on different paths. Like they'll say you choose to do this together and sink or swim together, or you guys work your case separate and the gentleman can, you know, end up being terminated. You can end up in reunification or those kind of things. So that's just kind of words they use for the clients to kind of put it in perspective for them that they're separating it. But it's not actually a separate case. It's just they have different treatment plans and maybe different permanency options at the end of the case.
Yeah, I don't know that. I'm like Terry. It would all still be one case in court. Now, maybe dad says, you know, I'm done with this. I'm just going to voluntarily relinquish my parental rights, or the court terminates his parental rights. And mom continues, but it's still the same court case. And it's
I've had a court case that there was domestic violence, and it's still the same court case, but they had to go in and bifurcate the hearings. So like dad has his own hearing where mom's not part of it. Mom has her own hearing. Dad's not part of it, but it's still all the same case, but they do have different hearing due to the domestic violence.
You have to tell me about that case, Amy, because I don't know what you're talking about.
That makes more sense.
Please submit that case, Amy. That'd be great.
There you go.
Shameless plug.
Do it. Do it. That would make sense because if they're not together, even though it's one case.
Yeah, but the thing is,
separated into
we find out
what he does and what they do.
Right. We find out on many, many occasions that they say they're not together. They testify that they're not together. And then we drop by and there he is. So, and that happened recently to us. So,
that happens all the time.
Yeah. So
is it a case of you can clearly tell that they're still living there, or they just dropped by for a few minutes? what I
They,
mean?
you can clearly tell that
They
they,
still live there?
yeah.
Gotcha.
Yes, even though they deny, it's like, this is just too quirky. No, we know.
With the number of court cases, at least in my area, that we're carrying in each county, the judges aren't often going to separate them out because they just don't have the judicial time either. I mean, we have more cases than days in a week.
Yeah, just in one county, we have about 200 kids in care. So, and that's just Mon County. Now, granted, that counts our youth service cases too, but.
We're coming up on the 2-minute mark here, so just want to make sure everybody's aware, and we get Amanda, if there's any last questions you wanted to ask the group or anybody else. And I also just wanted to say, Terry, with your form, could you send, if you're okay with the group getting that, could you send it to me and I can send it out to everybody on the call here today? If you're okay with that. Okay.
Yeah.
So kind
I
of one
think that was
final
helpful.
thought. Okay. Awesome.
Yeah, so Amanda, thanks for the case. And again, encourage people to submit cases. And if you're concerned about identifying information, sometimes we'll like change the number of kids or combine two cases to make it not identifiable, because so many of these cases have common features, that's okay too, or kind of make up a case based on a whole bunch of stuff that you commonly see. That would be worth discussion, because I think we can all really learn from the case presentations.
And all of us that are on here that are social service managers, if you have questions about a case, a specific case or something that's going on, I have no problem with people calling me and asking me general questions or saying, hey, why is this happening? Or is there a case manager that I can talk to? The supervisors are always mostly the same in those cases and involved. There's a lot of other people they can talk to besides just their new case manager.
Right. And anytime, I agree with Candy. I'm 100% like that too. And anytime we can get a release of information signed and we can all work together, that's even better. Because if we can be on the same page to do something to help our clients, then that's even better.
Yeah, and as far as for me, if you have any questions, please don't hesitate to call me. Leave me a message, call you back.
Well, we used to be the steady ones in the office, but with us being short staffed, we're all out there seeing people and doing things. So
Yeah,
right.
That's really helpful though, because there are times where, like, even this case, even though she wouldn't let me like collaborate, I would have loved to like just been like, hey, so can you tell me, like, is this accurate?
Hypothetically.
Yeah.
or in general, what's the process is
Right.
So, but it's never a problem. So if anybody has a question, all 3 of my supervisors are tenured supervisors. And I've been here 39 years. So please don't hesitate to call if you need something.
Right. If you guys want to put your numbers in the chat, then Jay can have those. That might be helpful if that would.
I do have a super quick question, and it was about something that was discussed earlier, about the mother being given fentanyl, and then it's showing up in like the drug screen. What are the odds of that showing up also in the infant's cord as well? Because I have a mom that I'm working with right now that tested negative actually on a urine drug screen, and then the cord came back for fentanyl, and a little bit later down the road I'm finding out like that the hospital gave her fentanyl. But I mean, if they're giving other patients fentanyl, I'm not seeing those babies have that in their cord. So we're just trying, I think that's the big issue is like, why is one testing positive, but the others are not?
So it depends at what time, like during the labor or delivery process, the mom was given fentanyl. So if it was like very late and the baby was almost out, so to speak, it might not be in the cord. If it was early in the laboring process, it will. So yeah, it's confusing, but both could be the case if she was administered fentanyl in kind of the delivery process, that it would show up in the cord or it wouldn't, depending on the timing when she was given the medication.
I mean, is there a way to track that? Because that can help us, because I mean, if we run into so many parents who are like, no, I don't use, cord comes back positive, and they're adamant that they don't use. We send them for a drug screen, and a couple of days later they do test positive. So, but then we find out also that hospital gave them this. So it's just kind of like up in the air sometimes for us to really know like where it's coming from.
Yeah, it's in the medical record, the exact time that the medication is administered. And we're trying to work with our medical providers to say, hey, you need to give CPS folks like your medical opinion because like it's a little bit like, I don't know what it means, like if they were given it at a certain time and when in the delivery that was. Like, it would be helpful for you guys to have the medical opinion of, yes, it was given at this time and it makes sense that it's in the cord. Or it doesn't, whatever the case is. So we continue to work with our folks here, and we'll try and get that information to you. I would like the patient to be discharged with it so they have it too, because literally they often do not know, which doesn't seem fair to them either. So great question, and we are working on that.
All right, everyone. Great question, Amy. Thank you for the discussion. I put the evaluation link in the chat. If you fill it out, that's how you get your CE. You'll have a week to do it. So next Wednesday is when it'll close. The link will also be in the recap email if you don't have it right now, if you weren't able to click on it. So no worries. And we will see you guys on December 7th. That is the next session. All right.
Thanks, everyone.
Thanks, everybody.
Thank you all.
Appreciate it.
Thank you.